Next would be in our agenda is a lecture on childhood obesity by Professor M.G. Satyadas, consultant pediatrician and professor in pediatrics, Teaching Hospital, Jaffna. I would like to call upon Dr. S. Vishnu, acting consultant pediatrician, Teaching Hospital, Batticaloa. Thank you.
Good afternoon, everyone. It's my great pleasure to welcome and introduce Professor Geetanjali Satyadas to the audience of this scientific session. I know this is much difficult to do it within a short time as her achievements are beyond the limit. But the thought that she is a woman of venture and simplicity, I feel excited to introduce her to everyone in this beautiful afternoon. I'm honored and proud to say that she is my teacher, examiner, and mentor. Professor Geetanjali graduated with MB.CHB from United Kingdom, and following that she did her postgraduate studies such as Diploma in Child Health and MD in Pediatrics from Postgraduate Institute of Medicine, University of Colombo. And she is the author in many index journals, and her findings are very useful for the beginners and followers. She has presented her finding in many national and international conferences. She has a special interest in teaching, and she rendered her services as lecturer in University of Colombo for a few years. Then she joined to the University of Jaffna, and still she is continuing her services. She is very proud woman, and her dedicated works, she is now turned as a professor in pediatrics. She is a member of many scientific professional bodies, and she is the immediate past president of Jaffna Medical Association. Childhood obesity is one of her prime interest and research topic, and today she is here with us to talk on childhood obesity, a call for the action. I'm sure it's going to be an interesting talk to us. With this note, I thank Professor Geetanjali for accepting our invitation and gracing our occasion. Dear Madam, over to you.
Thank you, Vishnu, for that kind introduction. And thank you, Batticaloa Medical Association, for giving me this opportunity to present my presentation today. I will see whether I can do justice to your call, Vishnu. I will be touching mainly upon the overall global, national, and local burden of the disease, causes and consequences, and the challenges that we face because of this problem, challenges in the management, and the preventive measures with a couple of evidences that we have found. So before going into the proper presentation, I would like to talk to you all about the Sri Lankan situation. You can see the GDP per capita for Sri Lanka. During the COVID-19, it has dropped a little bit, but the anticipated GDP has shown to increase. And the life expectancy of Sri Lanka is 76.98 for 2019. This is the World Bank report of Sri Lanka status. Gives us the situation of a middle income country with a good life expectancy. But if you look at the global trend and the future, you can see from 1990, the gray lines show a majority of the population was younger age group. And as we go on 2019, you can see the young age group is shrinking. And look at the predicted age groups that are predicted for 2100, that is 2100 years later. The middle group, the younger age group, the population is declining, and older age groups are surviving more and better. So this shows the global burden of disease is affecting the younger ages and the adolescent and young adults as well. So if you look at the good things about Sri Lanka, you can see the infant mortality rate has gone down to less than 10 currently, and you can see the female literacy rate reaching very high potentials above 90. Similarly, if you look at the global trend of diseases, you can see the infection diseases coming down and the predicted rate also coming down drastically. But look at the non-communicable diseases such as cancers, ischemic heart diseases, and the cerebrovascular diseases. Now they are showing a very exponential marked increase in the rate. If you look at Sri Lanka, has good control of the communicable disease because of the national immunization program, and the coverages and the drop in the rate of all these infections have come down drastically. But look at the non-communicable disease status in Sri Lanka. It is kind of doubling up and a rapid increase in the rate of ischemic heart disease over the last 10 years, increasing by 15.6%, diabetes increasing by 29.1%. And you can even see chronic kidney disease going up a lot. And of course, the lower respiratory tract infection, COPD, is also going up because of the environmental pollution. So this itself shows how the non-communicable diseases in Sri Lanka are very increasing rapidly. And on the right, you can see the cerebrovascular disease and how they are increasing as well. So if you look at the impact of these diseases, it doesn't not only affect the health system, it affects the economy as well as the individuals and the household. If you look at the economy, it reduces the labor supply, reduces labor outputs, additional costs to treat these people as insurance and productivity, lower returns of human capital investments, and so on. The health system is not only, it is also burdened by these situations by increased consumption of NCD-related healthcare, high medical treatment, very high sophisticated investigations and managements are done. So it is a very huge burden on the country's economy, especially on the health system as well. If you look at the household and individual, there is reduced well-being, there is increased disability, there is premature deaths, and household income is decreased because of the deaths and the disability, higher health expenditure, savings are lost and reduced opportunities. If you look at the household expenditure, especially on the medicines and the healthcare system on treating these individuals' non-communicable diseases, see how much importance and how much expenditure of they are spending on private doctors, medicines, private hospitals, lab tests, and so on. So there is a huge burden on the household and individuals because of these NCDs. Not only the country, it is the households are also affected by this. So Sri Lanka took the initiative and it has proposed few targets, NCD-related targets for 2020, but now it has been extended to 2025 because of the COVID-19. And you can see several activities have been planned. For example, 25% reduction in overall mortality and alcohol reduction, physical activity increasing, reducing salt consumption, reducing tobacco use, reducing the hypertension. But I would like to talk mainly about the halt in rising diabetes and obesity, as they have mentioned here. We are going to talk today about the obesity-related problems. So if you look at this obesity, worldwide obesity has more than doubled since 1980. And in 2014, you can see 11% of men and 15% of women are affected. Nearly 42 million children aged 5 are affected with overweight in 2013. It's not only in these years, but you can see Sri Lanka is also affected by 5.9% who are obese and 23.4% are overweight. Children are not alone in this situation. Children are also affected, and there is a rising trend in childhood obesity. If you look at the school-based survey done in 2015, reported by the Family Health Bureau, you can see the wasting, stunting, and overweight measured during the school medical inspections. And during the period of 2011 to 2015, rates of overweight in grade 10 children has risen from 2.5 to 4.2, and that is in 2015. Look at the situation now currently because of the COVID-19. You can see the global increase in the BMI. Estimated BMI has shot up in individual children. And not only that, in Sri Lanka also we have demonstrated that both wasting and overweight are increasing because of the COVID-19. And that is explained because of the time spent out of school during holiday closures is greater among those of the lower socioeconomic status, which is combined with the food insecurity which we encountered during the COVID-19. What have we found in the northern part of Sri Lanka? You can see this is a national survey, nutritional status done in the school children of northern Sri Lanka in 2018. And you can see we also demonstrated, but when compared to the global and the national levels, you can see overweight and obesity are increasing very rapidly in these children in these school-going age groups. If you look at the severity of the problem, now WHO has categorized into very severe, high, medium, low, and very low based on these values. If you put that onto our population, the northern province population, you can see wasting is very high, whereas overweight and obesity are on high increase and stunting is on medium range. So you can see in the northern part, we are faced with a double burden where undernutrition as well as overweight, obesity are rising in trend. So this also causes the risk of non-communicable diseases. Now risks are drivers and determinants are there. There is behavior, environmental and risk factors. There are metabolic risk factors and thereby they lead to non-communicable disease. And in children, these few factors, the globalization, genetics, the unhealthy diet, inadequate physical activity are promoting overweight and obesity. And thereby it leads to the non-communicable diseases in early life and early adult life as well. So if you look at the health risk related to obesity, the WHO in its technical report series has defined excess body fat is associated with adverse health outcome. And also in 1997, they defined the percentage fat mass that is in relation to the metabolic risks of getting non-communicable diseases. So males, they predicted 25% and females 32%. But if you look at the problem that we are facing here, now we use the BMI as the surrogate measure. Although fat mass is diagnostic yardstick for obesity, we are using BMI. If you look at the cutoff values used for these fat mass, it is questionable. We have not got validated cutoff values. And this fat mass varies with different ethnicity, different regions, and different economic status. So the most important message here is you can't unify the cutoff values that are appropriate for Western values to our Sri Lankan situation. So if you look at the body composition, a same height, same weight, same BMI person will have two different body composition. If you look at the same BMI, this is described by Hattori et al. In sometime back in 1997, I think, where you can see a single BMI line has different fat masses. So that is a crucial point we need to understand is when you are looking at one particular BMI, that doesn't mean that person has a one particular fat mass. There is a huge range of fat masses and fat-free masses for that particular BMI. That is actually assessed by these body compositions that we do usually using the bioimpedance electrical measure, and we were able to do it on our population when we studied this northern province children. So you can see when we plotted these children on this Hattori chart, the two dotted graphs are showing the vertical gain. One is for males and one is for the females. As children advance in age, usually we expect the BMI to go up. And with the advancing age, the gain in weight is more due to accumulation of fat rather than fat-free mass. That is why the line is more of a vertical nature. The fat mass is what is increasing as children age. Now you can see from these three graphs, the previous Sri Lankan study also shows a vertical increase. But whereas if you look at the USA and the UK studies, more of horizontal. That itself shows their weight increase over years is mainly due to fat-free mass, the lean body mass. Whereas in our children, the risk of getting metabolic derangement is high because we are demonstrating a vertical increase, and that is mainly because of the increase in fat content. So you can see our problem is more serious when compared to the other countries. So we cannot generalize the cutoff values used in other countries to our population. And this was described as metabolic syndrome by Gerard Raven in 1988 at his Banting lecture, where he said that metabolic syndrome is a collection of hypertension, obesity, raised triglycerides, and lowered HDL. So you can see we also have a lot of problems when you put these metabolic syndrome defined in adults into children. So there are many unanswered questions, and there are no age sex specific values are not available. And metabolic derangements are also seen in children aged 5 years. And as you can see, a single metabolic derangement, even a lowered HDL or even a raising triglycerides or an impaired glucose intolerance, a single metabolic derangement is enough to cause atherosclerotic damage, not necessarily metabolic syndrome. So the American Academy of Pediatrics has advocated that by treating a single derangement independently from the definition of metabolic syndrome is very important. So that is what we also should be doing. We should not be treating metabolic syndrome. We should be treating metabolic derangements in our children. So metabolic syndrome, as we have, it is accepted and it is there all over the world. People are practicing this. So you can see the vast variations in the definitions they use. WHO has defined, and these are some of the definitions they have used so far in the world. But currently accepted is the International Diabetic Federation consensus that is saying that obesity, weight circumference more than 90 with 2 of the other 5 metabolic derangements. If it is there, then that should be defined as metabolic syndrome. Interestingly, you can see the 6 to 10-year-olds, the metabolic syndrome cannot be diagnosed. Only you need to screen them if there is a family history of any metabolic derangement. But look what we found in our study. Even the 5 to 10-year-olds are having a marked changes, and our population, you can see a fair number of children are affected with metabolic derangements in the age of 5 to 10 years. And that is showing a statistically significant difference. The statistically significant value is seen in these children with who have an abnormal metabolic profile. So with that, we also checked the metabolic syndrome in our children, and it was sad to see that nearly 50% of these overweight and obese children had metabolic syndrome. You can see the breakdown at the bottom table where it says different ages, males, females, and the total. Nearly 50% of the overweight and obese children had metabolic syndrome. A sad situation. And we also went to define the percentage body fat that will predict the metabolic syndrome, and that will predict the risk of having non-communicable disease in later on life. And we did the ROC curve and determined the fat percentage that is appropriate, and you can see and marked in yellow, females had 23.1 and males, there is a risk when you have fat percentage above 21.6. And it clearly shows a difference between the various other studies that have been done. Even in Sri Lanka, you can see Vikramasinghe et al., they have shown 33.7 and 28.6, whereas in our study, we can also demonstrate there is a variation. So variations are seen with different regions, ethnicity, and also economic status. So country-wide normal values are needed. In addition to the metabolic syndrome and metabolic derangements, we also demonstrate that insulin resistance and inflammatory response are key issues for potential markers of cardiovascular diseases in recent years. And we also demonstrated that in our study as well. So if you look at the insulin resistance, how these children with acanthosis nigricans, more of our children with obesity have acanthosis nigricans. If you look at the HOMA-IR, where it is a measure of insulin resistance, the HOMA-IR value is to detect insulin resistance is 5.65. And most of these children who are obese had this problem of acanthosis nigricans and the risk of insulin resistance. In addition to these, there are other consequences that we need to be worried about adulthood obesity. Children, if they are obese, definitely they are going to be adult overweight and obesity. Thereby, that increases the morbidity and premature mortality in adults. We are also able to demonstrate the non-alcoholic fatty liver disease in our population. You can see nearly 26% had fatty liver demonstrated by ultrasonography, and liver derangements were seen as well. So if you look at the population, and it is known fact that 0 to 0.5% or 5% of all the non-alcoholic fatty liver disease develop cirrhosis in 10 to 20 years. So you can see the effect, the huge impact of these diseases have on children itself. So we need to really act very fast on these issues. In addition to metabolic derangements, insulin resistance, and non-alcoholic fatty liver disease, there are other problems that we have to think as well, such as gallstones, obstructive sleep apnea, and so on and so forth. Bone problems are there, benign intracranial hypertension, and polycystic ovarian disease, making these women with obesity having subfertile and having problems in pregnancy as well. So with that, I will just touch upon the psychological problems that we encounter. Obviously, children who are having overweight and obesity are depressed, they have poor quality of life, they have poor self-esteem, social acceptance is poor, and they also have weight-related victimization. And obviously, you will know that we tell these children who are obese to go and participate in sports activity, then they go and come back and tell us that the master or the teacher is not taking because we are unable to move because of the weight. So it's like a vicious cycle. They go for activity, but they are rejected because of their weight. So they are unable to improve on their weight. So this is a study showing that self-worth and athletic are significantly reduced in obese, and the appearance, the self-realization of the appearance also reduced in obesity-related children. So then we come to the management part. I would like to state Professor Kate Steinbeck, who has stated very clearly the children in this generation may be the first in the history to die before their parents because of health problems related to weight. So I would like to touch a little bit about the challenges we are facing, the early intervention and the prevention of NCDs, and how you would prevent obesity by intervening on early nutrition and weaning practices. So if you look at the treatment modality, the lifestyle modification is the key issue. And the management is based on child's lifestyle, comorbidities, the willingness to change. These children and these parents should be willing, they should be motivated to treat themselves and reduce weight and manage their weight problems. And we are here to support the family. So the target needs to be set because of depending on the stage of the puberty. So if a pre-pubertal child, you ask them to maintain weight, because when they shoot up in the height, they maintain weight, obviously the BMI comes down. But if it is puberty, they have past pubertal stage, you have to definitely tell them to reduce weight to overcome all the comorbidities. And you prefer a gradual change in behavior over a long period of time. So there are obesity intervention programs that have been done in developed countries, which have shown very clearly there's an improvement in steatosis, liver functions, and so on, with the reduction in weight. But look what we did. In our study, we were able to follow these children in 3 months, 6 months, 9 months, and 12 months. The intervention was giving a written care plan, and they met the dietitian frequently with a care plan, dedicated plan for physical activity. But when you look at these children, we had a massive dropout. Only from 170 odd, we were only able to follow 85 children up to 12 months. Massive dropout from these follow-up clinics. So because there's not much happening in these clinics. And if you look at the BMI, thankfully we were able to maintain a static BMI. There's no statistical significant difference that was demonstrated. It was just static. But we were thankful that because of that, our intervention, they remained static, that we were satisfied. But you can see there was no statistical improvement with this intervention. So whatever we do after they become obese is not going to help in the long term. So thereby, the prevention comes an important aspect. The primordial prevention and the intervention that we are to do in early nutrition and weaning practices. So this is explained by the fetal origin of adult diseases by Barker in 1994, where he explained undernutrition due to perinatal periods and explained by the thrifty genotype, where they grow up in an abnormal environment. They also have many adverse outcomes: insulin resistance, diabetes, hypertension, and hypercholesterolemia. In addition, there is another theory that is postulated by Singhal and Lucas, published in 2007, where if you see postnatal acceleration of growth, the children who are born small, term small for babies, and they show a rapid catch-up growth that is shown by the CHDR sample here in this graph, where you see a rapid weight gain. And that also has clearly shown that these children are having hypertension and increased fat mass at 8 years of age. So a rapid weight gain during the early period is not advocated, and it will cause more problems in your non-communicable disease. So what should we do and there is another theory here which I would like to tell at this point. The childhood obesity is a disease of environment, and it is a natural consequences of normal children with normal genes being raised in an unhealthy, abnormal environment. One other important aspect I would like to stress here is reported by Gary et al. In the journal Science, recently published during the COVID time. And what they demonstrate is when you are giving them the adequately modified microbiota containing diet during weaning period, their maturity, their growth potentials are far more better and they grow up to healthy children. So they have compared giving them artificial feeds to giving these children food prepared at home with fruits and vegetables and having homegrown corn and everything. If they feed those children with the home prepared food, their weight gain can be uniform. Their weight gain will be kind of gradual rather than the sudden increases and losses when you use these artificially commercially available food preparations. So future actions for us to take action is to, if a baby is born small, it is anticipated to remain small, to be safe rather than having a catch-up growth. So what we should be doing as doctors caring for children and the pediatricians, maintain on growth trajectory. You have to maintain your own growth trajectory. When you're feeding complementary feeding, we have to make sure that we are using complementary feeding that has representation and beneficial functions of the growth promoting bacterial taxa. So if you prepare the home-based food, which is effective, affordable, and culturally acceptable, it is far more better than the commercially available ones. And obviously, you need to breastfeed them exclusively for 6 months. And there are also these other promoting preventive measures where you promote physical activity, pregnancy weight gain should be looked after, and weight management, ending. You need to have all these other targets for prevention as well, in addition to these feeding and breastfeeding. So I would like to reiterate another point here where you have to adopt for policy changes in the social aspect. So if you look at this media advertisement for fast food, it's very attractive to child. A 20-second media advertisement is enough for them to adapt to that behavior. So we need to be very careful when you're advertising for these fast food, and there should be policies to limit these advertisements to less than 20 seconds. Ensure that school canteens sell nutritionally good quality food rather than having fast foods of rolls and patties and mixtures. Physical activity should be encouraged as a community-based activity. Maximize opportunity for safe walking, traffic regulations. It's a good presentation before lunch on traffic rules, and cycling to school and recreational activity, athletics. And also encourage physical activity. And the most important thing is on these footpaths, prevent fast food stalls on the way. And in addition, if anybody is giving incentive to retailers who give affordable fruit and vegetable for all. So with these policy changes, advocation, I would like to conclude my presentation summarizing that you can see there's a markedly increasing incidence of obesity causing exponential problems of non-communicable disease. Prevention and treatment must address multifactorial causes and consequences. And our goals as clinicians is to screen these children for obesity, identify the comorbidities, initiate preventive lifestyle interventions, advise on early weaning practices and breastfeeding, and also establish obesity clinics so that these children can be managed appropriately and safeguard our future generation from non-communicable disease and early death. Thank you so much.
Thank you very much, madam, for your talk with rich of information. And I know that that's photographs of yours. You are as a hobby, you have a photography. And we have some few minutes to accommodate few questions from the audience. Okay, in the absence of the questions, I'll thank once again Prof. Gitanjali Satyadas for to accept our invitation to talk in this scientific session. Thank you very much, madam.
Thank you, Vishnu, and thank you, Baticular Medical Association, for giving me this opportunity. Thank you.
Thank you, madam, for that excellent lecture.